South Africa, and it's in association with the University of New Mexico in the US. We have these sessions every Wednesday, and today is the pediatric turn. We've received 47 registrations from 10 different African countries, and I'm very glad to be able to introduce Dr. Dercksen today. And Dr. Dercksen is a PhD in clinical biochemistry from the University of Amsterdam, and she's currently the chief medical scientist at the Center of Human Metabolomics in Northwest University, Potchefstroom. So she's mainly interested in inherited metabolic disorders and chemical testing. And I think this is an area that's always stunned me. We struggle to make diagnoses in these children, and interaction and collaboration with science or medical scientists is really key to making this diagnosis. So I don't think Marli can hear us, but I'm going to give her a thumbs up and tell her she can start.
Thank you everyone. Sorry for the technical difficulties. So this is a long presentation. I may skip some slides, and there may be slides that I focus on more, but I hope I can cover a lot of work that's actually we cannot cover in an hour, but we will try and do it in an hour. So today I'm going to discuss to you a little bit about liver-related inherited metabolic disease, what is the clinical considerations, and what laboratory testing we should select in a pediatric setting. So the points of discussion, I'm just going to introduce to you some background with regards to hepatic dysfunction and inherited metabolic diseases. And then I'm going to divide inherited metabolic diseases in 3 subcategories and discuss hepatic disease in these 3 subcategories and show some case studies. So first I have to do a declaration, because I know there's a lot of specialists in the room. So I'm not a hepatologist or a pathologist or a clinician or who assess patients from day to day. I'm a medical scientist. I'm actually a lab geek. That's what I am. And I have expertise in inherited metabolic disease. So I focus on all the chemical reactions that happen daily in our bodies. And my life consists of what is happening in the lab. So I don't see any patients. So I do have experience in assessing clinical presentations, which doctors provide to us and then make recommendations. But furthermore, I do not see any patients on the patient level. So with regards to clinical assessment of patients, that's not my expertise. So I just need to give that declaration out again. So as I said, we are going to classify inborn errors of metabolism implicated in liver disease in these 3 subsections of IAM. So this is actually the 3 subsections that we also give clinicians, if it's a neurologist or a gastroenterologist. The classification always remains the same, but I adapted this classification so that it is implicated in liver disease specifically. So we're going to focus on these 3 subcategories. We're going to first focus on small molecules, which kind of results in an intoxication type of profile. And we're going to cover some disorders within this group. We're also going to have focus on the energy production and utilization disorders, and going to focus actually on mitochondrial fatty acid oxidation as well as glycogen storage disorders. And then when it comes to complex molecules, there will not be time to go into bile acid or CDGs or AAT deficiency, but we are going to focus on LSD specifically. So the clinical considerations when suspecting an IMD in a patient with hepatic presentation is that initially, the initial clinical presentation is very important. So we have to classify the hepatic disease initially. Normally, the patient are referred to us when this patient have progressive liver disease. We don't know what was the initial symptoms of the patient, and that's the most difficult part for us here at the lab. We don't know what the initial clinical presentation of the patient was. We also need to know the disease cause, if it was acute, if it was fluctuating, if it was progressive, or if there were any triggers like an infection or maybe anesthesia or some diet, so we need to know that as well. We need to know if it's only hepatic or if there is other multisystemic involvement. If there's unusual characters like pruritus, which are associated with the bile acid disorders, as well as maybe a funny smell that's associated with certain organic acidurias or urea cycle disorders. We need to know a little bit more about what the liver looks, or clinically, the clinical assessment of the liver is. So the size, the consistency, the age, which is very relevant in a pediatric patient. And then obviously the sonar results, which can then gives us more information with regards to the spleen involvement there as well. We need to know liver function test, and sometimes we need to have a cumulative report, so over a period of time. So if this patient maybe had fibrosis that progressed to cirrhosis, we need to know that disease progression, and other routine chemistry is also very important. And then poor or any response to treatment, we also need to know that. So if the coagulopathy is vitamin K responsive or not. And we need to know if there is a family history so that we can identify possible inheritance patterns. So is this maybe only males affected, and the mother may be then the carrier of a X-linked autosomal recessive or X-linked recessive disorder. So that is very, very important to us as well. So as I said, we need to define the liver pathology, and I think this is the bread and butter of the audience. I'm not going to go into detail into this, but we need to know how it started and how it progressed. So acute hepatitis, liver failure, did the fibrosis go into cirrhosis? Is there intrahepatic cholestasis, which is primarily then indicative of IMDs, and then extrahepatic cholestasis is not relevant in inherited metabolic diseases. We need to know if the hepatic or hepatosplenomegaly, if it's primary or secondary. So if there is any cardiac involvement as well. We need to know of unique or isolated liver pathology. So is there liver deposits in the biopsy of the liver of a specific patient? The presentation also depends if non-communicable disease or a communicable disease was excluded. So sometimes if you have an acute presentation, you need to run the communicable and non-communicable related testing in parallel. So you need to do your infectious disease as well as your inherited disease investigations in parallel. But if this is a slow progressive disease, we need to know if all communicable diseases was excluded. So we need to know, okay, focus, this is definitely a non-communicable disease. We need to know the age of the patient and what came first. I think I've emphasized that a lot. And then, for example, the stage of the disorder. So if we have a neonate with tyrosinemia type 1, may present with acute liver disease, but then may develop into cirrhosis and then go to cellular carcinoma. And then sometimes we are really, if the sample gets to our lab, it's really difficult because then there's advanced liver disease. And analyzing metabolites when there's advanced liver disease, it gives you a false impression of what the etiology may be. So it's very difficult then to use metabolites to pinpoint a metabolic disorder. We can still use enzymes to do that, but then a genetic way in diagnosing the patient is maybe the only way in which we will get a diagnosis. But that's why it's so important to get what was the first symptom, because that will assist us in selecting the appropriate metabolic testing. So I just want to, I actually covered this already, but one should really know that there's always exceptions to the rule, and it's very patient specific, and it's not always as clear cut as acute liver failure. Need to know that it can be associated with a urea cycle disorder, or your jaundice, liver failure, and hepatomegaly is galactosemia, tyrosinemia, Wilson's disease, or so it's not always clear cut. So, but I will discuss this later on in the following slides. So if I go back to the classification, I'm going to focus on the small molecules or intoxication-related metabolites. I'm going to go fast through these. I think most of you are well known with these, but I'm going to have one case study that I'm going to present to you as well. So if we focus on amino acid related disorders, then I can, all of us know hydrogenemia type 1, and that it can present with acute liver failure, hepatomegaly, and then development of cirrhosis and carcinoma. And then other symptoms may be renal tubular acidosis, which is also sometimes present in these patients. Hypermethionemia, we have two subtypes, which is the severe hypermethionemia. So typically, hypermethionemia has a primarily neurological component, but these two disorders has a reasonably large liver component as well. So in your S-adenosyl homocysteine hydrolase deficiency, you will see abnormal transaminases, chronic liver disease, and coagulopathy, but you must also recognize that there is myopathy as well as neurological features in these patients. The same with adenosine kinase deficiency. So they have raised ALT, hepatitis-like features, and they have coagulopathy as well, but they have subtle dysmorphic features such as frontal bossing and then erased CK as well. So they've also got megaloblastic anemia. So taking this into account can then really assist us in these patients. Citrullinemia type 2. So this is actually a transporter-related disorder in the urocycle disorder, and I've specifically put it in here because it's associated with intrahepatic cholestasis, where the AST and ALT may be increased. And then we also see that there is neurological aberrations in these patients as well. And then lysine protein tolerance, we have the patient with this disorder in our biobank, and these patients have hepatosplenomegaly, but with various different features. So you can see it's see that this is that most of the amino acid disorders are multisystemic, except maybe for your tyrosinemia type 1, but most are multisystemic, and we need to approach this in this order as well. In your organic acidurias, mostly it's associated with mild liver disease. And although urocycle disorders can sometimes be classified as organic acidurias, it can also be classified as amino acid related disorders, but I did put it here as organic acid related disorders. Your mevalonate kinase deficiency, we do see these patients in our country, and they have hepatosplenomegaly. Some of your branch chain amino acid disorders have late stage disease. And then you have your which are present in these different organic acidurias. I'm not going to go into much detail here, but also note that there's typically a trigger, such as protein intake, catabolism, illness, surgery, or medication. And there's also other clinical features, neurological features that's very specific. I'm going to present a case study to you of a 14-day-old boy with intermittent vomiting and loss of consciousness, neonatal encephalopathy, and extreme floppiness. And you can see this patient had a little bit of a high CO2, but not real indication of metabolic acidosis such. So the anion gap was normal in this patient. A little bit of conjugated hyperbiliary, and we did see a slight raise in AST, but not very much. And then your ammonia was literally through the roof. And then your viral and bacterial infections was excluded. And we recommended urine for organic acid analysis, amino acid analysis, and serum for organic acid analysis. And we found in this patient that the orotic acid was extremely high, and the glutamine was very, very high. And this patient was subsequently identified as an OTC patient. So typically we will then monitor the ammonia. Liver function will also be monitored in these patients, and then glutamine will also be monitored and needs to remain below 1000 micromole per liter. Then, which we all know is very prevalent in South Africa, it's part of the small molecule category, is galactosemia. As you know, there's 3 subtypes, which GALT deficiency is the most prevalent. And in South Africa, we have not as much classical galactosemia. We see more clinical variant galactosemia, where the GALT activity is between 1 and 10%. And in the Caucasian population, we typically see a lot of Duarte patients, which is still like a phenotypic conundrum for us if we need to treat or do not treat. International consensus is that we do not treat these patients. And as we know, it is prevalent, it's got a high prevalence in the Black population. And this is a nice publication of the National History of Classical Galactosemia, where they do discuss with us, discuss the clinical variant as well, which we see typically in our population and classical galactosemia. So clinical features, as I mentioned, it's noted as an intoxication. Intoxication-related disorder. You see hepatomegaly, hepatitis, or liver failure. And then you also see renal tubular acidosis in these patients. They are prone to E. coli infections, and they do improve with lactose withdrawal. And then later onset, we do see if lactose-free diet is not implemented, we see neurological deficits and sometimes the development of cataracts, and then the progressive of liver failure or hepatitis to liver cirrhosis. So the other 2 disorders, which is also in the galactose pathway, is the GALT and the GALT deficiency. So I haven't, in the more than 16, 17 years that I've worked at the lab, we haven't diagnosed a patient with these. And this is, again, just a summary of the two clinical presentations of GALT deficiency, which is primarily used. You do see the cataracts, and they do not have that severe liver involvement, where GALT deficiency has a large phenotypic variation. We get asymptomatic patients, and then we get severe patients with a GALT-related phenotype. So it's still a question is still posed here: is this in some patients a non-disease, or is it a disease? And I think this study here by the GlyNet registry indicates that it's very mutation specific. So these 2 papers are nice reviews on the other 2 disorders, and I think GALT deficiency may be of relevance in your field. So if we go to the second group of the classification, we do have our energy and production utilization related disorders. And sometimes people think that mitochondrial disorders should not be considered, but in South Africa, it's actually very, very important in the gastrointestinal medical community. So I'm just going to emphasize the importance with regards to a case study. And I'm actually going to give 3 case studies in this category, because I feel that we are missing cases in fatty acid oxidation disorders, glycogen storage disorders, and mitochondrial disorders. So this is actually a nice paper. It is a 2013 paper, but it summarizes well where the genes that gives a gastrointestinal related phenotype are summarized here in red, and also indicated in this picture, where the genes are actually involved. Even in your complex 3 deficiency, there's genes involved. We've got patients with, I think it's a BC cell deficiency, which is a complex 3 deficiency, which we initially thought was a GLUT2 deficiency, but they were diagnosed genetically with this, and they do excrete. They look much like a GLUT2 deficiency. Then in your disorders of mitochondrial DNA maintenance, this is the one that I'm going to focus on more, because this contains our MPV17 as well as our other mitochondrial DNA depletion syndromes, like your Pol gamma G as well. So I'm going to focus on MPV17, and I think most of you guys have maybe diagnosed a patient with this disorder because it's rather prevalent in South Africa, and the genetics is done in South Africa. On the other flip side of energy, so the one part is mitochondrial disease, but on the other flip side of energy utilization and production is in our glycogen utilization through the glycolysis, as well as glycogen synthesis and breakdown, and the role of fructose metabolism here. And this is actually a nice picture that's provided in this presentation, which is on myopathies in glycogen metabolism, but it also summarizes the liver-related disorders in this specific presentation. Firstly, I'm going to focus on the hepatic features in mitochondrial disease. It's again a nice illustration here from this paper from JMD, which was published in 2013, which you can already see the disorders such as Menche, which is mostly, it's typically seen in late onset cases, so you won't see that much in your pediatric population, although it may be different in our, in South Africa. It may well be that we do have a pediatric population with Menche syndrome, and this is due to pathogenic variants in the TIMP gene, and this results in pseudo-obstruction. And in your mitochondrial hepatopathies, which we're going to discuss, or your they also call it the hepatocerebral mitochondrial DNA depletion syndromes, your cycler deficiency here as well, and then your MLAS can result in enteropathy, and then your Pearson syndrome can result in pancreas insufficiency. And they have actually a nice table here in which genes are involved in certain with a liver profile as well. So they mention the neurological aberrations here as well, but they do mention that you must note that it's not only the neurological aberrations, but these patients may also have liver failure. So if you get a patient with a multisystemic involvement, primarily neurological and maybe more secondary liver failure, then these mitochondrial diseases should be considered. So this case I want to present is actually the patient presented at birth. The MRI was done. They saw volume loss, ventriculomegaly, thinning of the corpus callosum. That there was an abnormal EEG. The neurological features were hypertonia. The patient was actually blind, and the hepatic features were liver failure and hepatomegaly. So traditionally, this would have told me before the era of MPV17, I would have recommended very long chain fatty acids in these patients because they typically have these MRI findings, early presentation, neurological symptoms. And every time when we recommended very long chain fatty acids, it came back normal. So we had a lot of these patients which we had question marks of, and we thought that this must be a peroxisomal biogenesis disorder that we are missing in some way. I can well see that this patient had the routine chemistry of episodic hypoglycemia, coagulopathy, they had elevated ammonia, they have conjugated hyperbilies with transaminases that's elevated, and they normally have an metabolic acidosis. So this was actually the routine chemistry of this patient. So you can see really elevated AST/ALT in these patients with conjugated hyperbilirubinemia, and then the slightly raised ammonia. And what we saw here is, which is actually the thing that shouts out mitochondria, is that the lactate was 15.8. And in this patient, there was one time that the patient presented with hypoglycemia. So we did an organic acid profile, and what we saw was we definitely saw that there was high lactic acid. It correlated what we see on the bloods, and we did also see 4-hydroxyphenylactic acid, and this gives us an indication that there is a imbalance in NADH, and that is typically also associated with abnormal respiratory chain function in the mitochondria. We also see other liver-related metabolites. So we can see that it is something that gives us increased lactic acid with the increased liver-related metabolites. And even the orotic acid was a bit high, which correlates with the ammonia noted, and also with the liver disease. We see a rise in orotic acid in liver disease patients. This patient was particularly also referred to us so that we can evaluate if the 6-methylacetone acetone was absent, so that we can just rule out tyrosinemia type 1 in this patient as well. But clear cut, we see the lactic acid, we see the liver-related metabolites, and it shouts out mitochondrial disease, but we should also consider pyrorhodiogenase deficiency. We also did the amino acids, and again, a very good clue was the highly increased alanine that's reported here. And typically in mitochondrial disease, you see it with increased proline and threonine. And what we see if we have a liver-related patient or liver disease-related patient that is but is not amino acid related disorder, we see a rise in the tyrosine. We can see an increase in the methionine, but we see normal branch chain amino acids. So this typically says to you, okay, there's liver disease, but there's a specific notation of a high alanine, which gives you an indication that, listen, you must be on the lookout for a possible mitochondrial disorder here. We did do very long chain fatty acids because the clinical indication was that we also do it. Due to the high lactic acid, we also did a biotinidase deficiency, although it's a little bit contraindicated to us because of the hepatic features in this patient. And then our working diagnosis was that because we know of the hepatic cerebral mitochondrial DNA depletion syndromes in South Africa, is that mitochondrial or a possible pyruvate dehydrogenase deficiency. So the mutation is set up in South Africa, and this could have easily been then referred to. And this, I think the diagnosis was so quick because we know that this is a prevalent disease, and this is excellent work that was done with the team at UCT. And they've got specialists in mitochondrial disorders. So it indicates to us how important this finding is, because now we can, if the very long chain fatty acids is normal in these patients with a neurological phenotype and the liver-related aberrations, then we can immediately think of a hepatocerebral mitochondrial DNA depletion syndrome, which MPV17 is prevalent in South Africa. There's other hepatocerebral mitochondrial DNA depletion syndromes that should also be considered. So if your MPV17 is excluded, we mustn't just think that now it is totally excluded. We must think of the other genes, like your Golgi, that's also involved. So this patient was confirmed as having this nonsense mutation, and unfortunately no treatment is available, but at least the family have a diagnosis, and the prevalence is, as you guys know, it's really, really high. If we go back to, so I've covered mitochondrial disorders, and I'm now going to cover fatty acid oxidation disorders and hepatic features specifically in this. And when we think of mitochondrial fatty acid oxidation disorders in relation to liver disease, we think about disorders related to long chain fatty acid oxidation disorders or carnitine transporter disorders. So your short chain and your medium chain disorders doesn't have hepatic features, but your longer chain and your carnitine transporter related disorders have hepatic features with the associated cardiomyopathy. So they have hepatic features with hypoketotic hypoglycemia, but they can be sometimes ketones. They have hepatic encephalopathy, and they can have hepatitis or cholestasis. And here I just also mentioned the routine chemistry that we can see. We can see a hypoketotic hypoglycemia. We can see raised CK, transaminases, and lactate, but it's not that clear cut, and I will illustrate this later on in this presentation. Then one must remember that these patients typically present also with cardiomyopathy and peripheral neuropathy with a retinopathy in your trifunctional protein and your ALT deficiency. So we have this a 3-day-old female and metabolic decompensation at day 2, which was actually thinking of maybe this is organic aciduria or a urocycle disorder, because the patient had hypertonia, very lethargic. But what was a little bit against it was this patient already had an enlarged liver. There was hyperammonemia, but I'll show you the levels now, and which was an indication of possible inherited or genetic cause of disease, is that there was a previous sibling that died. And we received a newborn screening as well as routine metabolic testing in parallel at day 3 of life and a recollection at day 7 of life. And unfortunately, no material were available for genetic testing, but I'll focus on that now. So this was actually the liver function test that came through. And we did see there was a slight raise in the ALT. There wasn't any mentioning of the cardiac function in this patient, but there was a slight raise in the ALT. What was really, really extraordinary was this really high CK, and then the ammonia was not in relation to urocycle organic acid related disorder, so it was in the hundreds, and that's what you typically see with the fatty acid oxidation disorder. 100 to 160. It doesn't reach up to organic acid or urocycle disorders, which can be 300, 400 or thousands. So this was what we saw in this specific patient. In the newborn screening on day 3 of life, we could clearly see that there was an increase in the longer chain acylcarnitines, so C16 and C16OH, as well as the ratio. And we had a follow-up newborn screening, and the C16OH remained increased. So although the C16 here normalized, the C16OH actually remained increased and really increased. So we suspected isolated ALT deficiency or a trifunctional protein deficiency. So we use this in our newborn screening program. We use this specific post-analytical tool in our decision-making process. So we do not make, this is not a clear-cut decision. We utilize this with our results and the clinical presentation and the family history, etc., to make the diagnosis. But we can enter our acylcarnitine profiling into this platform of the Mayo Medical Laboratory in the USA. And they have thousands of patients with ALT or trifunctional protein deficiency. And they are listed here in this score range. And typically the score will tell you if the patient is very likely or possible or non-informative. And you can see that our patient file here is likely ALT or trifunctional protein patient. So this already, the comparison of this compared to other data of thousands of patients with disorder, with the related disorders, ALT or trifunctional protein, you can't distinguish between the two on metabolite level, already states to us that this is a possible disorder of fatty acid oxidation and long-chain fatty acid oxidation. And this is just a simplified, so we thought that it is in this late step in the longer chain that there is an issue. And at day 3 of life, they also send in organic acids because they thought that, okay, we must exclude organic aciduria as well. And they did everything in parallel. These clinicians were really, they wanted to make sure that we have the samples that we really need to make the diagnosis. And actually at day 3 of life, it's a perfect time to do a collection, specifically for a fatty acid oxidation, day 2, day 3, because the patient is catabolic at that stage. And we clearly could see that they were elevated 3-hydroxy-dicarboxylic acids, and the adipic acid was elevated as well. So we could clearly stipulate that this correlated with what the newborn screening profile said. But at day 7, we got a repeat sample in. And you would see here that we didn't see any 3-hydroxy-dicarboxylic acids. And it's because this patient was kept at anabolic status. So although the carnitine profile did give us still an indication, that's why acylcarnitines are so important in fatty acid oxidation disorders. The organic acid profile, actually, it wasn't normal, but it was typical of a very, very ill infant. And we didn't see that initial day 3-hydroxy-dicarboxylic aciduria that we did see. And it shows you in the importance of not just relying on organic acids, but using your acylcarnitine profiling to also get a confirmative diagnosis. And also with fatty acid oxidation disorders, it may be normal if your patient is anabolic at time of sample collection. So we actually got an indirect genetic confirmation of mitochondrial trifunctional protein deficiency. So no samples were available, but apparently there was a cousin which had a peripheral neuropathy, was diagnosed at the age of 15 with chocolate Mary tooth. He presented with cardiac features at the age of 10. He had transaminases. He had a very high CK, but he had no hepatomegaly yet. But there were definitely raised transaminases in these patients. There was a very large factor of consanguinity in this family. So the whole family was actually worked out. The cousin's mother and father, as well as the patient's mother and father, although we didn't have sample of the index patient. And the parents, as well as the cousin, all had the same mutations. And the cousin, it was a homozygous mutation in the trifunctional protein, the alpha subunit of the trifunctional protein, which is, this is the gene, the heart gene that was involved. And indirectly, we can now diagnose this patient based on the family genetics that was done, that this patient was actually then confirmed with the trifunctional protein deficiency. It is just, however, very, very strange that the cousin presented very differently than this neonate that died very early on in life, which again shows you the uniqueness of each patient. If we can go to the another section of energy utilization and production, we focus on glycogen storage diseases. And for this presentation, I'm going to focus on the liver-related disorder. So it can be autosomal or X-linked recessive, and the incidence is as high as 1 in 20,000. And I think we're missing a lot of these patients. Mostly types we see is 1 and type 2, which is Pompe disease, and type 1 is von Gierke of 1B. We see a lot of 1B genetics coming through in these patients. The treatment strategy is that you avoid fasting to prevent hypoglycemia. And I'm going to show you an application in a new approach in the treatment of these disorders, which is actually very novel. So we have, this is 3 nice papers that actually summarizes the biochemical and clinical aspects of glycogen storage diseases. So it's summarized nicely in these, and I also utilize these papers, specifically this paper, in giving the next few slides, because I think those are the most important. So you can go further into reading in the different subtypes of glycogen storage diseases, but I'm going to summarize it just in short for you and give an application of a case study. So this is a very daunting metabolic pathway of glycogen synthesis, glycogen utilization, which include the release of glycogen into glucose, which goes into your glycolysis pathway, and all contribute to the production in energy. So it's glycogen is in essence a way in which we can store glucose so that we can utilize it for energy in muscle as well as the liver. I'm not going to go into much detail in this. I think this slide is maybe very much more informative for you guys as gastroenterologists. So I went and I listed all the liver-related GSDs. So if you are wondering if you have a patient with hypoglycemia and hepatic features, specifically hepatomegaly, then these disorders can be considered. So as I indicated originally, 1A, you do see hepatomegaly. You see fasting ketotic hypoglycemia with an abnormal LFT. Typically also you see high triglycerides and high urate. And then the later stage or the secondary features in the specific disorder is in short stature or anemia. So I actually summarize it here as initial and then later stage, but it can also be seen as primary or secondary symptoms. So GSD1B is actually much more the opposite. You see hepatomegaly in the later stages of the disease, but you see this unique initial symptoms of neutropenia, recurrent infections. They have IBS anemia, and they do have fasting hypoglycemia. Then I'm not going to go into much detail. I just want to mention your GSD type 3, which also presents with hepatomegaly, fasting ketotic hypoglycemia, abnormal LFTs, and you do have glycogen deposits here in these patients. Interestingly, your GSD type 4, they present with hepatosplenomegaly and cirrhosis. So if you see these features in your initial presentation, then, and you do see a hypoglycemia with ketones, they also have later onset of cardiomyopathy, and in your liver biopsy they have this unusual glycogen-like structures which they call polyglycogen bodies. So this could sometimes I only say glycogen deposits, but some of the pathologists can classify it in polyglycogen bodies. Specifically. So it's glycogen deposits, but it's strange structure of glycogen deposits that we see in type 4. In type 6, we also see glycogen deposits with hepatomegaly. And then you actually get 4 type 9s, but 3 of them present with hepatic features, hepatomegaly. Then in your type 12, which is actually your fructose 1,6-biphosphate aldolase deficiency in your red blood cells, they have hepatosplenomegaly, which is a later onset feature, but their first feature is actually neurological deficits. And then we have your GSD type 14, which is actually also sometimes classified as a CDG. And CDG features typically consist of congenital abnormalities where you have subtle dysmorphic features, abnormal eyes, neurological deficits, and your later onset is the hepatopathy, chronic hepatitis, and cardiomyopathy. And then I just initially GLUT2 deficiency was not registered under GSDs, but it's now registered under or it was registered as GSD type 11, but it's now called Fanconi-Bickel syndrome. It's still registered under the GSD family, but it's named as Fanconi-Bickel syndrome. And typically you will see later onset hepatosplenomegaly with the initial presentation of tubular nephropathy and polyuria with increased excretion in your urine of glucose and galactose. So this is a nice summary of liver-related GSDs, and I think you can actually print this slide out and put it somewhere up because you can get so confused with all these different subtypes of glycogen storage disorders that this could actually be very informative just to have it up in your office and just to refer back if you get a patient with hypoglycemia and a fasting ketosis. So I already indicated to you that what's very important is that you have to have a low blood glucose, but you can have normal to elevated ketones. So typically on your liver presentation, you see elevated AST, ALT. You see aberrations on your lipogram. Some of them you can see a raised urate. So this is typically what we propose you do for a routine chemistry workup if you suspect a GSD. So this is the typical tests we do recommend. And then if you do have the privilege of doing a liver biopsy and you can see your glycogen deposits, then you know which subtypes to be on the lookout for. And if you have more specific hepatic features, then you know you have hepatomegaly or splenomegaly as well. Then I'm not going to go into too much detail on metabolic testing for GSDs because it remains challenging. There's no specific metabolites that we can utilize, with the exception of Pompe disease. We can utilize the dried blood spot enzyme testing, but for us, the routine biochemistry remains vital. And then based on this and your secondary metabolic findings, you can then go into genetic testing to kind of define what you get GSD, liver-related GSD gene panels or muscle-related GSD gene panels that you can do. And based on that, you can then diagnose your patient if you get a variance that has been previously noted as pathogenic. So I'm just going to give you an interesting case study on GSD, which I think is very relevant, seeing that there's now a treatment for this type of GSD. There was neurological features in this patient, including hypertonia. There were the gastroenterological findings were diarrhea, vomiting, and feeding, and there were reflux. There was not yet any hepatomegaly in this patient. There were recurrent infections. This patient was anemic. This patient had persistent neutropenia, and we couldn't really see why this patient had this persistent neutropenia. The mom said that the baby wanted to drink every 2 hours. And although hypoglycemia was reported by bedside monitoring, we do not have any formal test of that we could have access to. So I'm just giving you the routine chemistry. Now I just want to focus. So there's other relevant information here as well, but I want to focus on the ALT and AST, which you see, which show a persistent raise in the ALT and the AST. Not that much, but you see a persistent raise in it. Normal ammonia in this patient. The CK was normal. The glucose, like I said, were normal, but bedside monitoring was indicated that there was hypoglycemia. And unfortunately, we didn't have access to the complete blood count, but it was reported as they were persistent neutropenia. And then the urinary organic acids and seal carnitines were normal. We did this because of the hypoglycemia that was reported. And we recommended that a GSD panel be considered in this specific case. And this panel then indicated to us that this patient indeed had a GSD1B, which is the transporter, which transported glucose 6-phosphate into the endoplasmic reticulum so that it could be converted to glucose via the glucose 6-phosphatase, which is the enzyme involved in GSD type 1. So this patient actually had then a mutation that would confirm the diagnosis. Actually, the mechanism of the neutropenia was then that this transporter did not only transport glucose 6-phosphate, but was also a substrate, 1,5-anhydroglycidyl 6-phosphate is also a substrate for this specific transporter. So if you do not have a functional transporter, this would increase. It will inhibit your hexokinase activity and subsequently lead to neutrophil dysfunction and neutropenia. And these guys then said, but listen, there is actually a diabetic a treatment for historical treatment for diabetes, and they said that they are now going to inhibit this transporter so that you can excrete high amounts of glucose as well as this 1,5-anhydroglycosyl 6-phosphate, and you will excrete this in the urine, and it will not accumulate, and you will not get this neutrophil dysfunction. So they published this. The drug's called empagliflozin, and there was actually a big data study that they said this is actually a safe treatment option. 18% of the patients that present with hypoglycemia, but mostly the patients positive, well, there was a positive response. Actually, we are out of time, so I do not think I'm going to even go into complex molecules. I think Tim actually needs to arrange the second presentation that we can actually go into more detail in the complex molecules. But I hope I covered some of the liver-related diseases today in these two. But I think complex molecules actually needs a presentation on its own. And I hope it was informative for you today. I don't know what Tim thinks. Maybe he can just comment. Unfortunately, I cannot hear anything from my side. So I hope you enjoyed the presentation. I think we must just arrange maybe a second presentation for the complex molecule section. I think over to Tim.
Thank you very much, Marli. I'm assuming you still can't hear me, so I'm just busy calling you, and maybe you can hear from
Yes, I can hear you. Yes, I can hear you.
Tim, unmute.
Sorry, I was hoping that you would be able to hear me through Marli's microphone. Any questions so far from the audience? I don't see any hands.
Tim,
Marli,
just one comment from a liver-associated enzyme. Very good, Marli. Thank you very much. Very comprehensive. And
I think it's information. Let me just silent. I think it's information overload, actually. So I think to stop here, and we need another scheduled presentation, will actually be beneficial. But I didn't want to just go fast over everything. I wanted to give some clinical case studies for you as well, that you can see it. These cases are out there, and we need to be on the lookout. And this is South African cases that we diagnose. It's not literature cases that we diagnose. So that was actually the reason why I wanted to kind of put the case studies in, and I thought it would be too long. But I think we needed a second presentation that I can then focus on the complex molecules from there. I don't know if there's any questions. You can always email me on my email address as well. Tim can provide it. I think most of you guys have it. I don't know if there's anyone else that from Africa that's joining as well. But yeah, you can, if there's any questions you can provide. I'm putting it speaker again.
Tim, just a comment. Thank you, Marli. Very good. Just the nature of the liver-associated enzyme abnormalities, when you see a switch in the ALT-AST ratio, it's a bit of a red flag, indicating the AST might be coming from elsewhere, or perhaps a mitochondrial source. So the commonest cause from an adult hepatology point of view is to look for muscle or perhaps hemolysis.
Cardiac.
But that ALT-AST ratio is a red flag. And then when you know, if you're accompanied with the hypoglycemia and the ketosis and the lactic acidosis, then obviously you go on to looking for these disorders. But that would be a very good basic clinical red flag that you're dealing with something a little bit unusual than a regular hepatic pathology.
Perfect.
Yeah. From my side, Marli, I want to thank you very much. This is a topic that always stuns us and confuses us. And thank you for always being available on the other side of the phone to really look at it from a different perspective, because we look at it from a clinical perspective and we don't understand the pathways often. So thank you very much for that. I think this really was clear in terms of, you know, dividing up the types of cholestasis that we see, the different liver problems, and also suggesting what sort of screening tests can help us direct things, you know, like the CK. I think the lactates and the ammonia are critical to sort of point us in the right direction. And obviously screening urine organic acids and that sort of thing. I don't have any comments from the talk or any questions. So I have comments saying thank you very much for an excellent talk and a comprehensive and excellent presentation. So thank you, Marli. I agree. I would love to have another meeting on the complex molecules. It would have done everyone's brains and to listen to more information and complex things. So I think I'm going to end it there. I don't see any other questions. Chris, am I missing anything?
No, just if you can organize a follow-up, Marli, it would be very good. We'd really appreciate it. And there was an excellent turnout, max of 32. So there is an appetite here for this kind of talk. Thank you so much.
Yeah, so thank you very much, Marli. Thank you for the excellent talk. We look forward to part 2. Also, just to thank ECHO New Mexico and the ECHO India team for the technical support. There is a feedback form available in the chat. Please fill it in. And the recordings will be available on the Gastro Foundation website if you missed a part. So thanks to the Gastro Foundations, thanks to all the sponsors. And next week, we'll be having a meeting on IBD. Thanks, Marli.
Thanks, Tim.